Okay, now we're going to talk briefly about crisis assessment and interventions. We're going to cover the different characteristics of a crisis, as well as how you assess for it, how you treat it, and then what the different models are. Specifically, we'll go deeper into suicide, danger to others, grief, and grave disability. So, what's the definition of a crisis? It's a period of psychological disequilibrium experienced as a result of a hazardous event or situation that constitutes a significant problem that cannot be remedied by using familiar coping strategies. In other words, your old strategies don't work anymore. This is a time-limited thing, usually no more than 6 to 8 weeks, and if you don't resolve it appropriately, it could actually lead to long-term problems. So Golan, 1978, describes a crisis in terms of 5 components. First, they say something specific disrupts the person's life and equilibrium, and this initiates a chain of reactions. And you can think of events like retirement, marriage, unexpected death, all being something that would disrupt. Next, there's a vulnerable state. So the person experiences this, and then tension goes up. They're trying to use what they usually do to cope, and it's not successful. And if it's not successful, the tension is going to keep growing until functioning is impaired. The precipitating factor piece is when there's a final event in the series that just moves the person from being in this very vulnerable state to the actually disorganized state where it's become a crisis now. So this could be another hazardous thing, or it's kind of the straw that breaks the camel's back situation. A minor event just becomes catastrophic and the person is ineffective in coping. This then leads to the person to be in the active crisis state. Their coping is broken down, their tension is at a maximal level, and there's 3 stages here of this. Physical and psychological agitation, which could be food, sleep, problem solving, headaches, just the whole shebang. Secondly, you'll see that there's kind of a mental preoccupation and they're thinking about the events that led to it. And finally, you'll see that there's a return eventually to the equilibrium. So during the active crisis state, the person usually recognizes that they're not coping well, and they can actually be pretty motivated to seek and accept help in this stage. Reintegration is the 5th and final stage in this model, and this is when you come back to equilibrium, homeostasis. This follows the crisis, and it rests upon the person's ability to evaluate the situation and develop and use adaptive coping strategies. So what are the origins of crises? Well, there's certainly situations we can imagine, a car accident or unexpected job loss, rape, any sort of thing that threatens your sense of well-being. And then there's developmental. And now this is just something that occurs as we get older, and it's about struggling to go from one transition to another, becoming an adolescent, retiring, all of these things. And it's not universal because there can be different stages in different cultures, and people don't necessarily experience them during the course of normal development. What are your 4 basic types of crisis situations that you want to be familiar with as a psychologist? Well, suicide, certainly, assault, and then child and elder abuse, both being ones that we are mandated reporters for. Additionally, acute medical problems and withdrawal are very serious. Psychosis, eating disorders, disability, partner abuse, these are all ones where you can also see that physical safety is particularly in threat. So how do people respond to a crisis, especially something really catastrophic? Tyhurst in 57 said there's 3 overlapping phases to it. And the impact phase is what's immediate. It's a few minutes to a few hours, and this is where you have the shock. And even denial. Then you go into recoil, where the individual starts to acknowledge the reality of what just happened, and this is when symptoms actually intensify. Post-traumatic recovery is an alternating periods of adjustment and relapse. So the person becomes aware of what's happened, and they're kind of struggling to reestablish their state of equilibrium. How long this last depends on a lot of things, but the severity of the crisis for sure, the person, and then if they're being treated, how helpful and effective the treatment itself is. So those are your phases for a crisis. So what are the different symptoms that you'll see? Well, you're going to see symptoms in the emotional, cognitive, and behavioral domains. And I think we're all pretty familiar with the emotional symptoms like shock and disbelief, fear, anger, irritability. It can really be anything, and helplessness in particular. The cognitive symptoms, so mentally you can have flashbacks, intrusive thoughts and images, nightmares, things that you would normally associate with trauma, really, post-traumatic stress, confusion, memory, all that kind of stuff. And then behavioral symptoms can include normal functioning. It just diminishes. So if you were able to accomplish activities of daily living, all of a sudden, maybe you're not able to. You can't work. Some things that you're having inappropriate thoughts and feelings. And finally, it is important to add that you can have physical symptoms, really of every kind: digestive, sleep, food, and then you might see sort of the panic attack kind of things like sweating and dizziness and a startle response. So you have your phases: impact, recoil, post-traumatic recovery. You have your symptoms in the 4 different domains. Just picture someone, it's pretty easy to see. And then you have your risk factors. So we don't all respond to the same crisis in the same way. And there are different individual factors that might lead to a more severe, enduring reaction to disaster. So first, pre-event. So was there an unresolved trauma or something that happened before the actual trauma, crisis, event, hazardous event itself? Peri-events include sudden and unexpected events. So if it's a man-made versus natural disaster, or if it's prolonged exposure. So these are different aspects of the event itself that can make it worse. Did you think you were going to die? Was it horrific? Did you lose a lot in it? And then post-event factors, that would include things like, do you have guilt after? Are people supportive or are they not responsive? Do you have a social system or do you not? So you have the before, during, and after factors. Adverse reaction is also something you'll see with crisis. All of those symptoms that we know about with crisis can occur around the anniversary of something that precipitated a crisis. So if something happened right before your birthday, it's the day before your birthday, and you might start getting your flashbacks and depression. And people often find that just recognizing that can be very helpful. Finally, impact of culture. Effective interventions to people in different backgrounds really kind of are impacted by culture. It can influence what events precipitate crisis. For example, pregnancy out of wedlock, it might be okay in some cultures, but for some, it could be considered immoral and unacceptable and can really lead the person to huge crisis. As an example of impact of culture, individuals from Asian cultures tend to develop somatic symptoms in response to crisis. And because they value suppression of strong emotions, may experience increased stress when a crisis worker encourages them to focus and vent their feelings. So that's one other way. And how do you manage the crisis? Well, there's different skills that you as a psychologist need to have before you go in. So we're going to start talking about assessments and interventions and all of these kinds of things. But what's your basic equipment? Well, there's things you need to know about. So you need to know how to assess. You need to know how to resource and find resources for the family. In terms of working with the person, really first and foremost, you want to be able to establish an alliance in order to be helpful. In terms of assessment, you want to assess for risk factors. Do they need to be hospitalized? And what are the cultural issues here? Now, as you're working with them, you want to be able to include the family if it's appropriate, kind of look to the environment and reduce any risk factors that are immediate. And definitely be aware of your legal and ethical responsibilities anytime you're in a crisis situation. Finally, know what is short-term and what's long-term. So these are all aspects of what you need to know in terms of working with someone with a crisis, the knowledge, the skills, and the things you need to think through. So let's talk about the assessment. What happens when you walk into a crisis situation? Crisis assessment actually differs from other types of assessment in several ways. So we're going to talk about the characteristics that are unique to crisis assessment in particular. We're also going to talk about communication skills. So like I just said, establishing a therapeutic alliance is incredibly important. And what are those skills? And really nailing them down so that in a crisis situation you can use them is important. Assessment domains. So if you're assessing for a learning disability, that's one thing. But in a crisis situation, there are very specific things you want to assess for. And first and foremost, risk to life. The person, somebody else's, that you need to know, no question. And the different types of assessment here. 3 types to know about: the triage, crisis, and different ways of doing that, as well as the biopsychosocial. So let's go a little deeper into each of these. What are the characteristics of a crisis assessment differing from others? First of all, it's very specific and directive. This is about linking what you're doing and what you're assessing to the crisis resolution. So when a client learns during the assessment that their feelings like helplessness are normal, that awareness in itself is going to alleviate their reaction. So you link what's going on, the crisis, there was just an unexpected death, this person feels a certain way, you're going to make that link for yourself and for them. Second, the assessment focuses primarily on immediate problems, but it will address historical information in the sense that it's pertinent to understanding and resolving the current crisis. So this is not the time that you're going to do psychodynamic therapy. However, if the person's father just died, you might want to know just a little bit about what was going on. Did they even know, were they even in their dad's life or not? Like, you want to have a sense of the actual situation you're in. So you're going to get some information on that, but not for the purpose of psychoanalysis, but for the purpose of resolving the crisis with all the information you need. Third, the assessment's isn't something done to a person, but it's carried out with them. So the actual assessment process itself is both collaborative and actually kind of more part of healing the crisis than you would typically think of somebody who's getting assessed for a learning disability. You're really just getting information and taking it back. But in a crisis assessment, this is a process that you and the client are actively engaging in together. And within that assessment, you're also identifying the goals and the treatment plan and making decisions. So this is very targeted, very collaborative. And the assessment in and of itself is meant to really get you somewhere so that you have a plan in place for what's next by the time you're done with that assessment. So if you've ever been in a hospital, inpatient, or ER, there are some really specific skills. We all kind of are trained, especially just in dyads in class, in school, how to sit with someone. But to be really clear, especially when you're with someone who is psychotic or really, just unhinged, let's use a non-clinical term, what these specific skills are that can be very grounding for people. Allow time. So the first is silence. You want to allow the time for the client to speak and to facilitate catharsis, because just getting all of what's happened out often can lead to kind of a return to baseline. Depends on the crisis, but it can kind of settle their system a little bit. So being aware of not interrupting. And with any of these, making sure to be sincere about it, right? Like, even though we want to be really clear about the skills we use, this is really still coming from a place of empathy, sincerity, and from a sense of the therapist's presence. The second thing is you're going to attend non-verbally. So using one's own body language, because you want to let the person know that you are interested and you are concerned. People are scared and they feel alone, and if you can they might not be able to take in words, but they might be able to take in what your body is expressing to them. So nonverbal attending is very important. Restatement. So you let them talk, you're there with them. You're showing that in your body. Repeat the important information and confirm that you're accurately understanding it. So that's both for your purpose, because it can be kind of convoluted and they might not be very clear, so that you really understand what's going on and what's important. And now when you paraphrase, you can demonstrate to the client with your words, look, I understand and have empathy. So you're going to summarize the major points. So you're also kind of making coherent their experience when you paraphrase. And the fifth is reflecting back of emotion. So you're acknowledging and mirroring their emotional reactions. 6, you'll ask close-ended questions when you do ask questions. And that is for the purpose of obtaining specific information. Now, when you do ask questions for the purpose of more detailed information, there was an accident and you don't know what happened, you might ask, okay, where were you? How was that? Why did you do this? You might ask those more who, what, why, where. And then you can use those close-ended to just get very specific. Are you a danger to yourself would be an example of yes or no question. Or do you know where your son is? Where is he? Is pretty close-ended, I suppose. Okay, so those are your basic skills. Okay, assessment domains. Hoff, Hallisey, and Hoff propose that the assessment of clients experiencing a crisis should address the following domains. The 4 are risk to life, origins and development, manifestations, and the sociocultural factors. Every single client you see in a crisis situation should be assessed with regard to danger to self and others. And that means you're not only attending to what they say verbally, but really any other kinds of signs that may be nonverbal. Conduct a structured inquiry to collect information. So direct questions. If you think someone seems homicidal, you say, are you thinking of killing someone else? Very direct. Are you thinking of hurting or killing yourself if they seem suicidal? So if they've made a vague threat, you really need to frame and clarify, you said you sometimes feel like you can't keep going. Tell me what you mean by that. So, origins, severity, and development. So this aspect of the assessment is identifying the hazardous event and precipitating factors that led to their current distress. This information is going to help you determine if the distress is something that's like kind of chronic or if this is acute. So identify the phase that they are in, and that can help you identify what the appropriate intervention is. This can be difficult to identify as the precipitating event, especially when the client's problem has been present for a really long time, or if their report is really long and rambling. So this is why you use the direct questions. What event brought you here today? That can help identify the precipitating factor. So if the person was just raped, but they were abused as a child, you might have someone come in who's going, telling you their whole life story, and they're really upset, and this has triggered a whole lot of different stuff. But you want to know what just happened. So yes, there's a manifestation of chronic stress, but this person also is in an acute state, and you want to know what exactly happened so you can figure out what to do. Also assessing the manifestations. So you want to know, how did they interpret the event that led to the crisis? And what are their symptoms on all of the levels we talked about, emotional, cognitive, behavioral, and physical? And what are their coping strategies? How are they responding to this stress? When you know their interpretations, their symptoms, and their typical way of responding, you can identify what intervention strategies will be helpful and kind of get a baseline for the client as they progress. Useful questions during this phase can be, how do you feel about what just happened? How do you usually cope with stressful events? So let's note here when we talk about manifestations of crisis, when you evaluate, you want to interpret their symptoms as a normal response rather than signs of pathology. So if you assign a diagnosis to a person's reaction to a crisis, this may result in them viewing what's going on with them as an illness rather than an opportunity for growth. So if you say, you know what, you were traumatized as a child, you have chronic PTSD, I mean, that might be true. Maybe there are times where that's appropriate. But if someone was just raped, you really want to focus in terms of the crisis assessment and intervention. This is normal to be kind of falling apart or whatever's happening to them in response. So interpret symptoms as normal. Secondly, if possible, the client's pre-crisis functioning should be assessed to determine the extent to which the extent of change that they have experienced. So you can then know, is this atypical, or are these kinds of impairments actually a kind of chronic thing? Third, manifestation of crisis piece. How the client subjectively interprets the event is just key to the response they have. So you want to consider, is the client's interpretation consistent with the reality? And if not, does it differ from reality to the extent that it constitutes a threat to someone's well-being? To what extent is the client open to changing irrational beliefs? Keep in mind that socialization processes and value systems affect how people interpret things. So physical illness, death, and divorce really have different meanings to different people. And that could be just individual, or it could be cultural, ethnic, and religious. Final thing with assessing, look at the family, community, and sociocultural factors. Evaluate these relevant family factors, community resources, and cultural influences to clarify the origins of the crisis and the client's reaction to it, and to identify what alternatives are available to help them resolve it, to restore them to their pre-crisis level of functioning. For example, it's important to know the extent to which their ability to cope has been affected by their family's response, or how the family's been involved, and what material resources are there to help them cope. So you want to know the system part. So just to kind of overview, go back over that because it's really important. What's the first and foremost thing you want to think about when assessing for crisis? Risk to life. What do you do to make sure that you're really addressing that? You need to ask direct questions and clarify vague statements. What are the 3 other pieces that you want to be aware of when assessing crisis? The origin, severity, and development of it. So what precipitated the event, and to also identify to what extent something is long-term and what piece of it is current. Manifestations, you want to know how they interpret it, what their symptoms are, and how they typically respond to stress. You also, as you're reflecting back the manifestations to the client, you need to interpret it as normal, and for the purpose of treatment and resolution of crisis, get a sense of pre-crisis functioning, get a sense of how they've interpreted it, and correct any misinterpretations and take necessary steps if the interpretation is putting someone's well-being in jeopardy. And finally, look at the system. How is the system making it worse? How is the system able to help? And what material resources are available. So now we know the assessment domains, looking at risk to life, precipitating events, the manifestations in terms of interpretations and symptoms, and the systemic pieces. Now, what are the different types of assessments that you can do? And they might depend on the situation. Triage is the kind of assessment following a community disaster or other traumatic event, and it's conducted by frontline crisis intervention workers, otherwise known as first responders. You're obtaining the crucial demographic data, information about perception, coping, sources of support, safety, lethality. You're really going through everything. You want to know the mental status, symptoms, psychiatric conditions, environmental stressors, and ability to benefit from treatment. So the purpose here is just to determine, is intervention necessary? What is it? And you really want to be quick and thorough, but you need to know demographics, skill. You need to really quickly get through all of that stuff, but quickly and thoroughly. So do we need inpatient hospitalization, social service, support group, outpatient, and such? Okay, typical crisis assessment as defined by Roberts. The goals here are to provide a systematic method of organizing client information related to their personal characteristics, the parameters of the crisis episode, and the intensity and duration of the crisis. and then utilize this data to develop effective treatment plans. So an important aspect is distinguishing between normal reactions and reactions that are excessive and reflect a pre-existing condition or disorder. So you might be noticing at this point that there's a theme that when you're assessing crisis, a lot of people come into crises with things that have happened before, and not everyone was necessarily functioning so great before the hazardous event. So you are really piecing out what's normal and what's something that might be more chronic. There are different instruments available. Rapid assessment instruments are brief standardized self-report measures. You can administer them very easily, and you can then use them to monitor progress. Back depression inventory, for example. Semi-structured interviews have been developed for the purpose of crisis assessment. The triage model provides a framework for a semi-structured interview that involves assessing reactions on, the affective cognitive behavioral levels. The nature and the severity are recorded on a form, and the reactions that are identified as being the most severe are the initial targets for intervention. So first, the affective includes 3 types of reaction: anger, anxiety, sadness. Optimal interventions for clients whose strongest reactions are in this domain are the supportive strategies that validate their feelings, catharsis strategies, and awareness strategies so they can become more conscious. The cognitive domain is the perceptions of the event, and if this is the strongest piece for a client, you want to use strategies that help promote rational thinking, clarifying strategies to consider alternative interpretations, and delimiting strategies that help the client stop catastrophizing the crisis situation. Now, if the behavioral domain is the strongest, and that can be 3 different things. You're either avoiding, you're approaching, or you're immobile. So, fight, flight, or freeze. For these clients, you want to guide them to identify their resources. You want to protect them, whether it's themselves or others, you want to protect. And you also want to mobilize anything that can kind of come in to help them. Finally, the biopsychosocial assessment is used to obtain information on their biological functioning, psychological functioning, and sociocultural experiences that will be helpful for formulating treatment goals and a treatment plan. The amount of information you collect depends on several factors, including the severity and urgency. Note the amount of information collected from a client experiencing a developmental crisis may be fairly extensive, while information collected in an emergency situation can be limited to the identifying information, precipitating event, mental status, lethality, substance abuse, mental health history. So the really kind of bare bones needed information. And crisis test-taking strategies. So when you're taking the test, identify when you're reading the question, is this potentially a crisis situation? Because if it is, you want to start thinking through what you know about crisis and crisis assessment. When you read the events, you can, highlight if you're studying, but you can jot down and kind of mentally highlight things like how they appear, behave, what's their history diagnosis, what are these statements they're making, collateral. Make sure you kind of identify what the key components in the vignette are. From there, you want to assess from everything you know now, what is their current level of risk? Is there a further need for clarification assessment? And know the distinction between medical and psychiatric emergencies and the legal ethical responsibilities and limitations. So when faced with identify whether it's a crisis question, and if it is, look at all the pertinent information. First and foremost, always assess risk now that you know it's a crisis, and then start thinking through legal, ethical, medical, psychiatric stuff. Okay, so we've assessed for crisis. We've talked about what you do. You come onto the scene of a school shooting, whatever it might be. Now, how do you intervene? And so we're going to talk about interventions, what the goals are, what the difference is between a crisis intervention and just therapy itself, what the basic principles underlying this type of work is, what your tasks are. So you have goals, but you also have tasks. There are things you're going to do to get there. And how do you actually evaluate if it was effective? So the goals of crisis intervention. The goals depend on the nature of the crisis and the reaction, but typically they're going to include the following: relieve the symptoms, help the client understand, restore pre-crisis functioning, help them find better coping strategies, and finally, connect the current stress with past life experience. The first three goals must be addressed. The last two aren't always feasible, but they can be done in some situations. So relieve symptoms, identify understanding, and restore to pre-crisis are the necessary steps. And what's the difference between crisis intervention versus long-term therapy? So you can see here that when you come in, crisis, it's very focused, whereas long-term therapy, you do want to understand, their birth trauma. You want to really get a comprehensive assessment, and you want to know what their different diagnoses are. Whereas with crisis, if the person's schizophrenic, you do want some psychiatric information, but your goal is not diagnosing. It's just, providing a formal diagnosis. It's normalizing what's normal and figuring out if there's underlying pathology that's worsening it, just so you can identify appropriate crisis intervention. When in crisis, you're focusing on addressing the immediate traumatized aspects of the person. You're coming up with problem-specific plans using time-limited techniques to immediately resolve this. And you want to evaluate effectiveness. Did they go back to how they were before? Even if that wasn't great, are they kind of out of that worse state? But with long-term, you don't just want to address something that the client brings into the room that day. You want to understand what's deep down underlying the problems in the person's life. And based on that, you're coming up with something. So basically, you're coming up with something comprehensive. And this is going to address more long-term needs. So if the client has kind of baseline moderate anxiety, you don't deal with that in the crisis intervention. You might have an understanding of it to help facilitate teaching them new adaptive strategies to deal with the hazardous event and return to functioning. But you're not taking on their generalized anxiety disorder here. But in long-term therapy, you are. And you can use lots of techniques. You can have some that are short-term. So you can give them a skill to walk out and use that week to help deal with some specific thing in their life. But you're addressing different goals, not just something very time-limited about one thing. And finally, how do you evaluate? Well, you want to look at their overall functioning at the end of treatment. So it's not necessarily that, hey, are they at the same place when they entered treatment? That actually might not be great because they came into treatment because something wasn't working and you want it to improve. So typically, you would see an improvement in functioning in a longer-term therapy. What are the principles? So there are 7 core principles underlying crisis intervention. Proximity, so the crisis that's ordinarily provided in surroundings that are close to their normal area of functioning or where the event occurred. You want to provide it as soon as possible. You need to expectancy, you need to instill hope. Brevity, 1 to 5 contacts with the client. Simplicity, this is really a simple intervention, one issue at a time. Innovation, modify routine interventions to fit the situation and client. And finally, practicality. So if it's useful, it's going to have to be carried out by the client. So it might be the best intervention in the world, but if they're not going to do it, that's not what you want to use. What are your tasks when you go in to intervene? Your goal here is to help to relieve the symptoms, help them identify what's going on, restore them. What are your tasks? Physical survival, expression of feelings, cognitive mastery, and behavioral and interpersonal adjustments. That means again, risk to life. You're preventing suicide, homicide, dealing with abuse situations. You are identifying and expressing the feelings related and understanding how they impact well-being. Cognitive mastery, you want to get them back to reality. So if they have irrational beliefs and fears about this, you want to get, it's going to help to have a more rational assessment of the situation. No question. Unless it's denial, in which case, that it might get worse first, but they're going to be out of the denial eventually. So you want to be there to help them get through that. And behavioral and interpersonal adjustments. If someone just died, for example, how do they need to adapt and change in their daily life activities, their relationships? And how do you minimize long-term negative consequences? So if they want to go tell their brother that their dad died because of him, and that would be a way to work interpersonally and say, okay, well, maybe let's wait on that. The 7-stage crisis intervention model is from Roberts in 2000, and this has 7 stages. Crisis assessment first, see what's going on, establish rapport, so form a bond with the client. Third, identify the major problems. Fourth, explore their feelings and emotions around them. Fifth, start generating and exploring alternatives. And 6, develop and implement an action plan. And then the 7th stage, of course, is a follow-up. So what are methods here? So let's talk about both intervention approaches and intervention alternatives. So there's 3 primary approaches: non-directive, collaborative, and directive. Non-directive is the client's able to initiate and perform things. The crisis worker is more of a facilitator to help them make a decision. So they're being supportive, encouraging, and reinforcing. So a collaborative approach is most effective for a client who cannot function effectively with non-directive approach, but they still have sufficient mobility to work collaboratively with the crisis worker. In this case, the worker's role is as a catalyst, a facilitator, a consultant, and a provider of support. Finally, a directive approach is appropriate when the client's too immobile to cope effectively with his or her crisis due, for example, to severe depression or anxiety, maybe a severe psychotic episode, or impaired reality testing. In this approach, the crisis worker is assuming temporary responsibility and controls and defines problems, alternative solutions, and facilitates their ability to take action by providing instruction and explicit guidance. Intervention alternatives. So specific crisis intervention strategies include psychological first aid, group, individual, family, and referrals. What is psychological first aid? These are mental health services that you provide immediately following exposure to a disaster, and the idea is to bolster the individual's sense of safety, well-being, and empowerment. Processing interventions have been shown to perhaps, instead of being helpful, be harmful, but providing warm blankets and such things are certainly important pieces of psychological first aid. Group interventions. There's a number of approaches. Critical incident stress management is a multimodal approach for individuals who've been exposed to a disaster or other traumatic event. And this combines group therapy with individual counseling and support, family interventions, follow-up services, and referrals. Individual interventions can include behavior therapy, CBT, and solution-focused. Family is preferred when it's for kids and adolescents. Referrals are often necessary in any of these situations to refer the clients to the agencies or services that will really be able to assist them with things like their medical problems, substance abuse. If there's severe mental health, they may need to be hospitalized, financial, legal issues. For example, the emergency room is an important referral for immediate medical treatment. You might want to network with the police and sheriff for protection of the client or therapist. Tarasoff type reporting, enforcement of a restraining order, reporting child abuse and elder abuse. And a physician is a referral for a medical exam if the client's health status is in question or they've been injured and not received attention. Suicide assessment and treatment. This is crucial, and you want to know both about the goals and methods of assessment, as well as knowing what your actual approaches can be to achieving the aims. So what are your goals, your assessment goals? Well, you want to determine the future and imminent risk for suicide first and foremost, obtain information, basic information about them, develop a treatment plan, and then monitor their treatment. The initial suicide assessment of a client involves integrating information from a variety of sources, including a clinical interview, mental status exam, the client's family members, the client's physician, other healthcare providers, and psychological tests. So, suicide assessment, you're going to assess for risk and protective factors. So what are the things here that put them at further risk, and what are the things here that are protective? Information obtained through interview of the patient and therapist observation will be critical in assessing for suicidality. When it's possible to review records and consult, this is really important to do. So that can be psychological records or medical records, consulting with other treatment providers, interviewing family members, and using instruments and scales that are designed to measure suicidality, like the Beck Suicide Scale. When you're assessing, you want to think about things in terms of ideation, intent, plan, and means. These are the 4 categories. The intensity and duration. So when thinking about ideation, you want to think about how intense and how long. When you think about the plan, how specific is it really? When you think about the means in the plan, you want to think of how prepared are they really to do this? And then you want to think, how lethal are they? How do they have access to means, and do they have the means? So these are ways of thinking through those 4 pieces. Another thing to know in terms of risk factor is that previous suicide attempts and a family history of suicide are huge risk factors. In fact, their own personal history of previous attempts is the strongest indicator. So as you assess, we kind of overviewed this, but you're going to want to think psychiatric history, current mental status, so you're thinking about their psychology both in the past and the present. Then you want to think also just about their kind of different layers, which is their physical body, sort of what are their basic demographic characteristics, and then where are they placed in kind of their world economically and socially right now. Do they have access to resources? Is there a lack of resources? What's their culture? What's their religion? So you really want to get a sense of the community they're embedded in, because that's huge. So very important to know that Caucasian males, middle-aged, divorced, immigrant status, those are demographic ding-ding-dings for potential lethality. In terms of mental status, a depressed mood, hopelessness, helplessness, guilt, impaired thinking, poor judgment, hallucinations, delusions, impulsivity, and aggression are all increasing the risk factor. In terms of their psychiatric history, more than 90% of people who kill themselves have a comorbid psychiatric diagnosis, actually. And the diagnoses that are most commonly associated include depression, which is, expected, as well as schizophrenia, substance abuse, and personality disorders. So even though borderline clients are often kind of said to just be making dramatic attempts, well, maybe they are making threats sometimes, but they also have a much higher risk of following through on suicide. It might be 20%, but don't quote me on that. Or 200%, I don't know. Schizophrenia and substance abuse, you can understand that with the impaired reality testing and the lack of inhibition with substance abuse, how that would increase your chances. And also just always remembering that it's when the client has kind of emerged a little bit from a very severe depressive crisis that they can in some ways be at the most risk, because they actually have the energy to carry out a suicide plan. So let's review risk factors. Just here's the general overview. So your suicidal thoughts and behaviors, number 1. Number 2, certain psychiatric diagnoses, depression, bipolar, substance abuse, borderline, schizophrenia. Number 3, certain particular psychiatric symptoms, including hopelessness, dysphoria, severe or chronic anxiety. Number 4, certain physical illnesses, particularly neurological disorders and HIV/AIDS. Number 5, demographic characteristics. In general, older white males are at greatest risk for completed suicide. In general, so those are the top risk factors categories. In general, the greater the number of risk factors and the fewer protective, the higher the risk. However, certain risk factors carry more weight than others. So the presence of a concrete, detailed, and lethal suicide plan and the means to carry it out suggest a high risk, even when no other risk factors are present. So what about questions that you could be asked on possible harm issues? Important to know that the Board of Psychology and Consumer Affairs are linked. The board is in fact under the Department of Consumer Affairs. So anything to do with suicide or homicide is actually hugely important to the the Department of Consumer Affairs, and that does influence things. Direct questions. So when you are assessing for harm, it's important to remember that you want to ask the client directly about harm issues. Knowing for the test that men kill themselves at 4 to 5 times the rate of women is important. It's statistically significant. And if you are given a multiple choice question where 2 options are men and 2 options are female, one of the options that's a man is going to in almost all likelihood be the correct answer. When people so age, older, also really important for the test questions. Know this line. At the age of 45, there is a jump. There is an uptick. As age goes up, the rate goes up. So that there's also an uptick at 65 and 70. And 75 happens to be the biggest jump of them all. 45 is the first, 65, 70, and then 75 is this very crucial, huge jump. Know about the CDC study. So the highest death rate is when comparing white and black males. While the number has run close together, the white males at every age group rate higher. So you're going to want to pick white male over other ethnicities. And this is in contrast to something from the EPPP that had data about Native American populations. So just forget about that for the CPSE. Basically, overall, when you put together the studies, men, gender, and age, 70 to 75-year-old white males have the highest death rate. It is alarming. It is staggering. Native Americans not going to be the answer, and I guess I'm telling you now, but maybe try to forget that 19 to 34-year-old Native American men have a high rate of suicide. And then remember it when you're back in practice. Suicide and diagnoses that increase the risk. So let's talk a little bit more about these diagnoses that are risk factors. Bruce Bomberg wrote a book. They picked a lot of questions from him and his book about these things. There are a handful of diagnoses that are really potent in increasing the risk. And, as we've gone over, depression, but particularly with psychotic features, bipolar 1, clearly, borderline, alcohol dependency, and schizophrenia, schizoaffective 5th. So really, when you have a thought disorder piece that comes along with it, it increases suicide rates. So that's why major depression versus with psychotic features would be more, because you have impaired reality testing, your executive functioning is not intact. There's also a bias in the exam when you're talking about risk factors. And the bias is the word plan, P-L-A-N, plan. If you were to, so you might ask a client, this might be on the test, question, if you were to commit suicide, have you thought about how you would do it? This is essential in terms of assessing for risk, because if someone has an actual specific plan, that's really the most predictive thing, despite all these other risk factors that you know about. Suicide screening questions. So we kind of started moving into that, but let's just get a little deeper into it. You want to be really direct and go through the list that we discussed of thoughts, plans, behaviors, and intent. This is really the critical aspect of the assessment, and the nature of the questions will vary depending on the situation and the client characteristics. But in most cases, questioning should begin with general questions that address feelings about living. So you'd want to start with things like, do you ever feel that life isn't worth living? And then you progress to more specific questions about suicidal ideation and behavior. So you might not want to jump out at the gate, sit down with this person you've never talked to and say, hey, do you have a gun? Do you plan to shoot yourself? You're probably going to scare them off and maybe not actually get as meaningful of information. And you're kind of leading them there. So you're really just starting with, what are your feelings about life and if it's worth living? Then you're kind of getting them to go into the territory of their thought process around life and death. And then you can start saying, so what are your thoughts about this? You could start going, have you ever thought about actually moving forward with this? That's getting into intent. Then you might say, okay, so you've been thinking about it a lot. You're thinking it might be something you want to move forward on. Do you have a sense of how you might go about that if you were going to kill yourself? And they might say, well, I don't know. And that's a good sign that maybe they're not too far down the line. But if they say, oh yeah, I would shoot myself, then you go to means, which is huge. Do you have access to a gun? So these are kinds of the ways you want to progress, but you want to make sure to hit thoughts, plans, behaviors, and intent. What about suicide in the law? Important to remember that reporting suicide is actually never required by law. So when you say to your client, I'm sorry, I have to breach confidentiality, you're a harm to yourself, that is not necessarily true legally. However, you have ethical obligation as you are allowed to breach confidentiality in this case. So while not required by law, you are certainly permitted if you believe they are a suicide risk. This is not a 5150. However, it's I think 2400. And if you don't report a client who is actively suicidal, you could be facing a huge malpractice issue because you're not really being a competent therapist if you're not doing, breaching confidentiality when it is appropriate as a licensed clinical psychologist to do so. So that is important to remember. And right, so it's not required by law. And just remembering too, suicide is never a duty to warn. So we have Tarasoff, we have duty to warn, we have Ewing and Goldstein. This has to do with someone's a danger to others. There's a specific person that's a reasonably identifiable victim. This is not something suicide. Oh, well, they're a reasonably identified victim to themselves. No. That is not 5150. It is not Tarasoff. So when you want to look at the risk factors of ideation, plan, and plan with behavioral steps, you can think about it in terms of 3 rings. Ideation is the lowest. In terms of this, at least in this realm, just ideation lower. When you get to plan, you're getting higher. This is, I've been ruminating, I've been saving up some of my pills. But a plan with a behavioral step, this is I find, let's see, I started selling my things. That is a plan that has started. This is a plan that is in action. And this is profoundly worrisome. So when you hear that some step of the plan has really been taken, like I started selling my things, I have my will in order, you're talking about a pretty serious risk. So what do you do? Well, what about a suicide contract? Is that a reasonable thing to do? Absolutely not. There will never be an answer where the use of a suicide contract will be correct. You are never, if you really think that someone is a danger to themselves, you are risking mayhem by sending them home with a no suicide contract. If that you set that and the client then kills themselves, legally you're in big trouble. Because if you're saying, the lawyer might ask you, hey, is suicide a rational act? You say no. Would you sign a contract with an irrational person? And you say no on the stand. Then you basically said, so I signed a contract with a person I knew to be irrational. That's not going to look very good in court. And 1 out of 3 therapists will probably lose a client to suicide in the course of their careers. And so this is something you want to think seriously about. Two different psychological tests worth knowing about, both in your own practice as well as for the test, are the Beck scale for suicide ideation, the Beck hopelessness scale, and reasons for living inventory. So what are your goals of treating someone when they are a danger to themselves? As described by Goodwin and Jameson, the primary goals of treatment are to deal with safety, alliance, and alleviating risk symptoms. So, what does that mean? 1, ensure the client's safety by eliminating or reducing access to common methods of suicide. Have the person get rid of their gun, have the person turn in excess medication that they've stored up. So that's ensuring safety. 2, establish an alliance by developing trust and rapport. You want them to confide in you. You want them to be open so that you can work together to actually deal with the problem. And 3, alleviate acute risk symptoms that are amenable to treatment. Panic, agitation, insomnia, substance abuse. So if they're in you might want to refer them to the psychiatrist, but you want to get them sleeping. You want to get them off drugs. These acute risk factors, you want to deal with them. The secondary goal, however, is to reduce future risks by addressing kind of these overriding things like mania, depression, other conditions. So, perhaps you kind of cut this hypomanic episode or wherever they're at, they're taking drugs now, they're not staying up all night, but you want to deal with these things that are going to make it prone to happening again. That's secondary though. What are the different ways you can approach this? Well, here are some of the alternatives. Hospitalization, outpatient crisis intervention, and outpatient psychotherapy. Hospitalization is appropriate for a client who's just attempted suicide or is really at imminent risk. And this means, they have a plan, they have access to lethal means, and there's other risk factors like they're not thinking correctly, they're being impulsive, chemical dependency, all these risk factors you know of. Lack of social support, in fact, is one. The initial thing is to encourage voluntary hospitalization. That is the best scenario. However, an involuntary hold should be initiated if the client refuses to enter voluntarily, if they're really in this much of a crisis. Outpatient crisis intervention is appropriate when they're at moderate risk, so there's an intent and access to means. However, they do have judgment and support, and they are willing to comply. So they are not like, let me get on with this. I want to do it. I have the means, and I can't even think straight. These are people who are like, oh my God, I want to die. I have a gun, but I don't want to do it. I have, they're able to think rationally. You can get them in an outpatient crisis intervention situation. Outpatient psychotherapy, this is usually, if you're dealing with a suicide crisis, then this is going to usually be the follow-up to either the hospitalization or crisis intervention. Or if you have a client who really is at a very low risk, but there's someone who has they don't have any means or plan, but they have this thought like, I think I'm going to have to do this at some point. So if you have someone who has suicidal ideation, maybe even some intent, but they have support, they are willing to talk about it, they're willing to comply with treatment, then outpatient psychotherapy can be appropriate. And CBT, interpersonal, dialectical, and problem-solving therapy are ones that have been identified as beneficial. So that's, really plays into the CBT bias that you will see on the exam. And it makes sense that if you're talking about something that's kind of more crisis-oriented, solve a problem, suicide-oriented, that you're going to have one of these strategies as emphasized. So, as we talked about, primary goals are ensuring safety, establishing alliance, alleviating acute symptoms. The secondary goal is reducing risk by addressing conditions and risk factors. And then to review your alternatives for treatment or hospitalization, you've got impaired thinking in this one, outpatient crisis intervention. They're moderate risk, but they still can think and have some willingness to comply. And outpatient psychotherapy, when you have either as follow-up or you've got low-risk clients who are willing to engage in healing process. So danger to others, assessment and treatment. There's a lot of issues here. Legal and ethical are issues. Yeah, you've got a number of things that you want to think about here.